Welcome, everyone, and thank you for joining me this afternoon or this evening, depending on what time zone you are in. My name is Dr. Joy Boyd Holmes, and today we are going to be discussing caries prevention strategies, how to incorporate current treatment modalities into clinical practice. As a reminder, all listeners should apply their own professional judgment and experience with respect to all of the information that will be provided. I do want to thank VOCO for providing an unrestricted educational grant to support this evening's continuing education activity. Just a little bit about me. I am a dental hygienist. I have over 25 years of clinical experience. I received my initial training at Howard University School of Dentistry. That's where I received my certificate and went on to receive a Bachelor of Science in Dental Hygiene from the University of Maryland, Baltimore School of Dentistry. I received advanced degrees, my master's and doctorate from Nova Southeastern University. I currently own my own company, Dr. Joy RDH, and co-founder for Gel Ed. I am on the editorial review board for Inside Dental Hygiene and the clinical advisory board for VTAL. And then I hold a number of board positions, including the Maryland State Board of Dental Examiners, Maryland Dental Action Coalition, amongst others. So let's get started. What are our objectives for today? First, we're going to re-examine the prevalence and etiology of dental caries. Next, we're going to describe the latest technological advancements along with their mechanism of action for preventing and arresting dental decay. We are going to discuss the importance of utilizing a caries risk assessment with integrating new treatment modalities and preventative measures for the management of dental caries. And last, we're going to discuss current practice guidelines for the evaluation, detection, and prevention and treatment of dental caries. So you're probably thinking, what in the world could I possibly learn about dental caries at this point in my professional career? Well, in my opinion, a lot actually. I've been lecturing about caries for quite some time now as a part of my nutrition lectures. And in preparation for this webinar, like many others, I reviewed the current research and treatment methods, and actually I'm still learning quite a few things. You see, the research behind cariology, which is the studies of caries, is ongoing. And for that reason, new information will continually be available to oral healthcare professionals, along with changes in how we view, approach, treat, and manage this global health burden. If you take nothing else from this webinar, I want you to take this, and that is change how you talk about dental caries. And so instead of calling it dental caries like I have it listed here, I think it's more appropriate for us to call it caries disease. I find that when we simply talk about conditions, sometimes they just go left unchecked. But when you tell someone they have a disease, or we talk about something as if it's a disease, I believe we make more of a concerted effort to manage that disease and to treat that disease. Again, caries disease is a global health problem. The goal, the ultimate goal today is to provide you with some basic information that you can share with your patient chairside without overwhelming them with all of the science. So where are we currently? Okay. Currently, an estimated 2.3 billion people suffer from tooth decay of permanent teeth globally. Untreated tooth decay in permanent teeth is the most common health condition globally, and more than 530 million children suffer from tooth decay of their primary teeth. Dr. Kim Cooch, who is an expert in cariology, in his book entitled Why Me? The Unfair Reason Why You Get Cavities and What to Do About It, states the following. Dental caries, the disease that causes cavities, is the number one disease of mankind. And I want you to sit with that for a minute. Caries disease is the number one disease of mankind. In his book, he goes on to say that caries disease impacts every country and every demographic in every country. Caries disease is complex to diagnose. It can be complex to treat. Getting to the root cause of caries disease can be challenging. And with all of that being said, the rate of dental caries continues to grow. and the oral health burden remains unchanged. What is the best way to talk about caries disease when we're talking to our patients? How do we incorporate the best caries prevention strategies and treatment modalities into everyday clinical practice? Well, the first thing that needs to happen is for you, the dental healthcare professionals, to have a solid understanding of what contributes to caries disease, but more importantly, to teach your patients to view their oral and systemic health in a different way. We need to teach our patients that they are a part of the care team and encourage them to take a more proactive approach to their oral health. Dr. Cooch notes that many dental professionals fall into the trap of oversimplifying what is going on, okay? Not just with overall health, but with caries as well. And I've been guilty of this myself, we try to keep it really quick and simple. And when this happens, sometimes our patients do not fully understand the disease. And when they don't understand the disease, it's difficult for them to be a part of the healthcare team. In medicine, there's an established model to assist with patients being more involved with their healthcare and taking a more proactive approach. And this is called P4. This model is now being applied to dentistry. The 4 Ps represent an integrative and proactive approach to healthcare, okay? This was introduced into medicine approximately 16 years ago. This systems biology approach to health and disease integrates lifestyle, environmental factors, biology, biomarkers, and clinical data, okay? And so what are the 4 Ps? Predictive, okay? This means that disorders, diseases can be accurately predicted by precursors and other tools before the initial symptoms occur. Preventive, interventions can be implemented for the predicted disease to prevent damage to health. Personalized, meaning it's patient-centered healthcare that is individualized for each unique patient. And then participatory, patients participate in their healthcare with sharing of information and shared decision-making. So let's look at these individually. Okay, so predictive, again, you are preparing for a problem before there is a problem. So the goal here with P4, when we're talking about predictive, is to identify the illnesses before symptoms develop. Here, it means screening for genetic factors, learning what early symptoms look like before the problems develop, and using knowledge about current health to predict future health. Now, with preventative, it's having the tools to prevent the potential problems before there's an actual problem. So this allows the healthcare team to recognize early signs of illnesses to avoid serious illnesses. So enjoying health versus managing chronic illnesses. So we know it is all about prevention. Next, we have personalized, and that's the custom-made health management plan. With this personalized focus, treatments are really focusing on wellness and staying healthy instead of trying to get better. With this, we are eliminating the one-size-fits-all approach to treatment. So if you think about it, if a patient comes into the office and they present with a carious lesion, automatically it's drill and fill. Well, what you're going to learn later on is that there are new stages and how you identify a carious lesion, and based on which stage or score you give this carious lesion will determine how you approach that tooth with treatment. So again, it's just not a one size fit all. And then last, we have participatory, and that is the patient becoming a well-informed decision maker, part of their own healthcare team. They are responsible for directing their own healthcare. They are responsible for making decisions based on conditions, risk, and options to control those conditions, ultimately becoming fully a part of their own healthcare team with decision-making abilities. So when we apply P4 in dentistry, simply stating, if disease can be accurately predicted at the patient level, targeted interventions to prevent the disease from occurring become possible rather than reactively treating its manifestations. And so I see this paradigm shift in dentistry, and I'm really excited about it. So let's talk about dental caries. Let's talk about caries disease. Okay, caries disease is considered a disease of modern civilization. Why? Because prehistoric man rarely suffered from tooth destruction. And you can see the timeline that I have listed here. In the pre-Neolithic periods, there were skulls that did not exhibit any dental caries, okay? But we know that dental caries has been around for thousands and thousands of years. So when we talk about dental caries, it's important that we have a solid understanding of what's happening in the mouth, okay? We call our mouths the oral microbiome. So it is the second largest microbiome in the body next to the gut, okay? And within healthy individuals in the mouth, we want the host and the microbial communities to live in a homeostatic balance. But what causes this equilibrium to be disrupted? Typically, you have poor oral hygiene, you have inflammatory or autoimmune diseases, you have immunodeficiency disorders, you have a diet maybe that's rich in low molecular carbohydrates, and you have other health issues. Now, you have over 1,000 different bacterial species and an estimated number of around 20 billion residents that exist in the oral cavity on non-shedding surfaces of the teeth and the epithelial mucosal surfaces. Together, they can form biofilms, and they differ in composition based on the location in the mouth, the surface, the oral health status, and again, these environmental conditions that I just talked about, okay? What happens is that there's a shift in pH, okay, when this homeostasis is thrown off. And this is when the pathogenic bacteria begin to thrive, all righty? So that's really, really important to note. This is a nice quote from Benjamin Franklin, and I put this in a lot of my presentations, especially when I'm talking about dental caries. And it says, hot things, sharp things, sweet things, cold things, all wrap the teeth and make them look like old things. So we want to get into a more scientific definition of dental caries or caries disease. They are caused by an imbalance of the biofilm, okay? The imbalance is not cured by simply filling the hole or simply removing the decay and filling the hole. What is so sad is that dental caries, although complex, is completely treatable and controllable if you have a solid understanding of what is going on and what you can do to help the condition. So when we talk about dental caries, it's important to understand the human tooth. So the human tooth is made up of 3 layers. Of course, we know that's the enamel, dentin, and the pulp. They are both comprised of inorganic material called hydroxyapatite crystals. The surface absorbs these acidic glycoproteins from saliva, and that is what forms the slimy layer called the acquired enamel pellicle. So at its surface, the tooth surface has a net negative charge, and so does the bacteria. And so initially that creates the repulsion. However, when plaque biofilm is introduced, this defense mechanism is broken down. And so plaque grows when the starches and sugars are introduced in the oral cavity through the human diet. With that being said, caries disease is a biofilm-mediated disease, and it cannot occur in the absence of dietary sugars. So what is the cause of caries disease? This is another quote. And I stand on this. No single parameter is responsible for the formation of a carious lesion. There are a combination of factors involved. And over the next few slides, we will talk about some of these factors. Keep in mind, there can be other factors outside of what's listed above. So lack of saliva. There are really 5 main things that contributes to caries disease. These 5 main things are lack of saliva, diet, which is the incorporation of fermentable carbohydrates, the bacteria in the plaque biofilm, genetics, and pH. You also have host factors that need to be considered. So like the tooth surface, sometimes people have deep pits and fissures, food selection and dietary patterns. That really fits in with diet in general, oral hygiene habits. Once again, other genetic factors, time and frequency, and really talking about how you're ingesting your food, how often, are you leaving any time in between? So again, if you're drinking coffee, are you drinking it straight or are you just sipping on it throughout the day? Race, age, and ethnic groups, those are other host factors, and of course, socioeconomic status. Now, there is some research that is in its infancy that links Candida albicans to early childhood caries. I know a lot of times when we talk about caries disease, we're really focused on bacteria, but there's research that states that Candida albicans has a positive correlation with cariogenic traits of Streptococcus mutans in early childhood caries-related biofilm of young children. There's also other research in its infancy, and I'm just going to read this on the slide. It says the immune system may be a key player in caries formation and recurrent caries under existing restorations. So when bacteria invade the oral cavity, the body sends out neutrophils to attack. But as these neutrophils track down and destroy this invading bacteria, this may cause destruction to the localized environment as well as the bacteria. So the analogy that I often like to use is I see a fly on the wall, or just a really, really big bug, I'm probably going to pick up a shoe and smack the wall. I killed the bug, but then there's also damage to the wall. So let's talk about biofilm. I think sometimes when we talk about biofilm, we connect it with periodontal problems, but it's important to note that biofilm is also responsible for caries disease. Biofilm is a complex communal three-dimensional arrangement of bacteria. So based on this simple definition, what is the big deal with biofilm? Why do we need to be concerned about it? Why does it give us such a run for our money and wreak havoc in the mouth and the body? Again, biofilm imbalance contributes to caries disease. So biofilms, again, are organized to maximize energy, spatial arrangements, communication, and continuity of the community of microorganisms. The biofilms protect bacteria living within their structures, and therefore they provide an advantage over free-floating bacteria. There is this slimy extracellular matrix produced by the biofilm, and that encloses the microbial community, and it protects it from the surrounding environment, and it keeps the bacteria banded together so they are not easily flushed away by the action of the saliva and the gingival trabecular fluid. This matrix helps to protect the bacteria deep within the biofilm from antibiotics and antiseptics, and it also helps to increase the likelihood of the colony's survival. So mechanical methods like toothbrushing, interdental cleaning, professional scaling procedures, those are going to be required regularly, and they need to be done to effectively disrupt and remove this biofilm. You can use antiseptics and mouth rinses to help control the biofilm, but they have to be formulated as to be able to penetrate that plaque matrix and gain access to that pathogenic bacteria. If you take a look at the pictures here, you will see that biofilms have a unique architectural structure. The bacteria within the biofilm are not uniformly distributed throughout the biofilm, so they present as aggregates of microcolonies, and you can see that they vary in different shapes and sizes, and you will also note the channels between the colonies. This allows for circulation of nutrients and byproducts, and it provides a system to eliminate waste. So bacteria in this biofilm communicate with each other by a process called quorum sensing. And this enables bacteria to monitor each other's presence and to modulate their gene expression in response to the number of bacteria in a given biofilm. And so this essentially can coordinate disease progression. This here is just an infographic of the life cycle of a biofilm. So you can see here, you have the initial attachment, colonization, the coadhesion, the maturation, and then last you have the detachment. What we want to do as oral healthcare professionals, and what we want to make sure that we are instructing our patients to do, is to remove the biofilm before it colonizes and it permanently attaches. This is going to be really, really important. Next. You have the microbial growth, the reproduction, and the coadhesion. And we talked about this a little earlier, but it's throughout this process, a part of this process, where you have the sophisticated system where the bacteria are eliminated waste. But believe it or not, this waste, this byproduct or these byproducts can be used by food for more pathogenic microorganisms. So one microbe's waste is another microbe's treasure. The biofilm controls whether or not minerals are staying on the teeth, okay, or if they're moving out of the teeth. So another factor that is responsible for caries disease, we just talked about the biofilm, is saliva. And saliva is a wonderful thing. It works with your body in a variety of ways to help maintain overall health. So the saliva works with the oral cavity, it works with the digestive system, and it works with the immune system. So in terms of working with the digestive system, of course, your saliva initiates the chemical digestion of carbohydrates in the mouth. With the regards to the immune system, your saliva helps to defend the body against germs that enter the mouth. And I always like to say, remember, 90% of all diseases typically will manifest themselves in the mouth first. So you can think of it like a first line or second line of defense. And then, of course, saliva works in the oral cavity to help keep the teeth mineralized. So from a karyoprotective standpoint, how does saliva function? Well, it offers a buffering capacity. So our saliva contains bicarbonate, phosphate, protein, and that all helps to neutralize acids produced from the carbohydrate metabolism. The goal is to get the pH in the mouth back to 7. So every time we eat or drink something, that pH balance is affected and it typically drops. Our saliva also contains calcium, phosphate, and fluoride, and that is what helps to assist with the remineralization. If someone has adequate flow of saliva, it enables rapid transport from the mouth, so things are able to flow easily. Our salivary glands are developed during the 4th week in utero, and so the nutrients necessary for developing proper salivary functioning are your vitamin A, iron, and protein. So if you're ever having a conversation with someone who is considering getting pregnant or is currently pregnant, this is a great conversation to have. It is important to have as much saliva in our mouth as possible. Now, of course, anything in excess is never good, okay? But we definitely need to have a sufficient amount. So from a scientific standpoint, if we think about our saliva, if we think of it as an unstable solution with dissolved material in it, the more saturated the solution, the more dissolved particles you will have that will fall out easily. So in our mouths, these particles are the calcium, the phosphate, and the fluoride. And so when the particles fall out of this solution, they can be deposited on the tooth to enhance that remineralization. Dry mouth is what occurs when we do not have sufficient salivary flow. A significant portion of the population suffers from what we call xerostomia. The number is even higher for those who take medication, and it increases for each new medication added. So anywhere from 20 to 50%, according to some research, of the population will suffer from xerostomia or dry mouth. And again, that number increases to 70%. If the person is just taking one medication, of course, it triples with the, when you start to add more medication. Common medications that affect dry mouth include your pain medications, your allergy and cold medications, any of the medications that are used to treat anxiety, so forth and so on. So in addition to medications causing dry mouth, sometimes there are genetic factors that cause it. Smoking, I just don't like to say tobacco anymore because we know that people are smoking just about anything nowadays. You also have the vaping and the e-cigs. So I just say smoking in general. Mouth breathing definitely can cause dry mouth. Different systemic illnesses, autoimmune diseases, and diabetes. And then, of course, if you have a diet that's not rich in what it is that your body needs, that can impact your salivary flow as well. So speaking of diet, when we talk about diet, a lot of times we really reference carbohydrates when we are talking about caries. And of course, carbohydrates isn't the end all be all, but we only have an hour. So I'm going to specifically focus on carbohydrates because those are the sugars. And so the dietary classification of carbohydrates we have here, we have our monosaccharides, which would be your fructose, your glucose, and your galactose. Your disaccharides, so you have your sucrose, your maltose, and your lactose, and then you have your polysaccharides. When we're talking about sugar, it's important to note that sugar is classified differently, okay? So you have your natural sugars, and so those are located in the cellular structure of your grains, your fruits, your vegetables, your milk, and your milk products. But then you have free sugars, and those are sugars that are added to a food or drink, or sugar that is already in honey, syrup, and fruit juice, and then added sugar. And so these are sugars that have been removed from their natural source and added to foods. And so we call these free sugars because they're not inside the cells of the food we eat. To further clarify, added sugars are typically all of your mono and disaccharides, your honey, your syrups, your agave, and your nectars. And so the World Health Organization issued a guideline for sugar intake for adults and children for both oral and systemic health. And they indicated that the intake of free sugar should be reduced throughout a person's lifetime. The intake of free sugar should not exceed 10% of total caloric consumption daily. This helps to lower dental caries. And the first two are strong recommendations, okay? Now, why does it matter if a recommendation is strong or conditional? Typically, strong recommendations have enough evidence, enough science, enough research to support the implementation of policy. Now, there was a conditional recommendation, and this was to consume less than 5% of free sugar. And this helps to benefit, you'll put yourself at a lower risk throughout your lifetime for caries if you're consuming less than 5%. So the problem is that free sugar is literally in most everything we eat. So if you think about it, a typical adult typically shouldn't have more than 25 grams of sugar per day. If you are someone who likes to drink soda, cola, or pop, I'm not sure what you call it, that could have 49 grams in just one drink. That's so you haven't eaten anything, you haven't drank anything else. You just had that one thing of soda. And now I want you to think about if you supersize it. So there was an interesting meme I saw on social media, and I'm not sure how true it is, but I mean, it definitely got my attention. And it said that by the time a child is 8 or 10 years old, they would have consumed more sugar in their lifetime than someone who their entire lifetime 100 years ago. So you think in someone 100 years ago who died at the age of 80, this child living in today's society at the age of 8 or 10 has consumed more sugar than that person did in their entire lifetime. Again, it is in everything that we eat, and it is in everything that we drink. So when we talk about diet and carbohydrates, fermentable carbohydrates are what we really need to focus on. Fermentable carbohydrates are foods that are broken down to sugars in the mouth by the salivary amylase, and it causes the pH to drop below 5.5. So let's talk about pH. In the mouth, pH operates as selection pressure. And so selection pressure is the extent to which organisms possessing a particular characteristic are either eliminated or favored by environmental demands. And so in the oral cavity, selection pressure controls whether your biofilm is normal or if it's malfunctioning. So when we talk about pH, we cannot ignore the Stephen curve. And so this is the frequency and severity of attacks on teeth that can be influenced by a number of factors. So typically it takes into account how long we're grazing on food or drinks over a period of time. And then when we do this for long periods of time, it increases our exposure to bacteria and from those sugars, from those fermentable carbs. And so again, this increases the exposure of teeth to acids. Foods that typically stick to teeth will increase exposure of teeth to acids since they remain in the mouth longer. So Stevens curve, in essence, explains how long it takes for the oral cavity to return to a neutral state after an acid challenge. In the mouth, enamel is highly susceptible when it falls below that critical pH at 5.5. It is important to note that root dentin is susceptible at 6.7. So again, every time you eat or drink an acidic beverage or you consume a fermentable food, the pH in your mouth can fall below a critical level. So again, for you coffee drinkers, if you're sipping, are you sipping throughout the day? If so, every time you take a sip, okay, your teeth are experiencing an acid challenge, okay? Think about how many acid challenges your teeth could possibly undergo each day. In our mouths, it's important to note that our teeth are constantly, or our mouths are constantly in a state of demineralization or remineralization. And this is constant, okay? The remineralization process is very slow. And if the demineralization of enamel exceeds the remineralization repair process, the caries process will begin. So it's always important that we do things to influence a higher pH above 7. And you can see based on the infographic here, again, diet control. It says brushing and flossing teeth. I would change that to say interdental care. We're going to increase our calcium and phosphate intake, fluoride treatments, and of course, no smoking. So what does modern management of caries disease look like? Dr. Dominic Zero holds a position. He's the director of the Oral Health Research Institute and professor in the Department of Preventive and Community Dentistry at Indiana University. And he discussed management of caries as a disease process, and he outlined the following. He stated that we should be detecting and assessing at an earlier age. We should be determining risk. We should be making a diagnosis if the disease is present. We need to be establishing a prognosis. We should be intervening, okay? And by intervening, we intervene through preventative measures by arresting or reversing. And this is typically accomplished by elimination or modification of etiological factors that we discussed earlier, also by enhancing some protective factors. This can occur through treatments, which we will discuss briefly, like fluorides, sealants, different paste, toothpaste and creams, and glass ionomers. And then we want to be able to delay restorative treatment whenever possible. So detecting and assessing caries disease. Traditional methods involved visual and tactile methods. I do want to state that it is no longer acceptable to use the sharp end of an explorer to detect caries. By doing so, you can possibly accelerate the caries rate. X-rays were also used. The new trend now is the use of electronic devices. Using a visual guide along with an electronic device for a second opinion is a good strategy. There are so many breakthrough technologies with detecting caries, even the use of a scanner. There are also different lights that are available. I know one company, Designs for Vision, uses a fluorescent light, and that actually can help you to see a carious lesion where you would not normally see it with your naked eye. Now, the way that we classify caries, that it's totally different from when I graduated, and I graduated in 1997. So one way that is being used is the International Caries Detection and Assessment System, ICDAS. It is an evidence-based system which would permit standardized caries detection and diagnosis in different environments and situations. This is what people wanted to do, and that's why this was developed. It was developed to bring forward the current understanding of the process of initiation and progression of dental caries to the field of epidemiological and clinical research. So this system allows us to record the severity and incidence of caries in its continuum. And so that's very important. Now, there were two versions of ICDAS. The first one was in 2002, and then the second one was in 2005. Now, currently the ADA uses certain components of ICDAS. Again, it allows us to record the severity and incidence of caries in its continuum. It is important to note that the primary requirement for applying the ICTIS system, you have to clean and dry the teeth. So looking at this, this is very, very different from what I learned in school. But if we are applying that P4 model here to dentistry, again, it's not a one size fit all. You know, there's been new staging and grading for perio disease, and I would not be shocked if this caries classification system continued to change. You also have the International Caries Classification and Management System. This was built on the ICDOS to provide an international consensus on a comprehensive, risk-based, minimally invasive, and preventatively oriented caries management system. So this was collaboratively developed between 2010 and 2017 with several dental research and practice organizations. Caries risk assessment. The best tool to use to predict future risk of caries is actually a past history of caries. But why is it so very important? Why should we use them? Why are caries risk assessments so important? Well, number one, we need to determine if additional diagnostic assessments are needed. Do we need to test a salivary flow? Caries risk assessments allow us to identify the primary etiological factors to determine the best interventions and control measures. Caries risk assessments help us to guide treatment, so whether that be restorative treatment or preventative treatment. We're able to assess caries control measures with a caries risk assessment, and then we are able to determine the timing of recare. So we should not just base our recare appointments off of periodontal concerns. We also need to determine it off of caries risk as well. There are various different caries risk assessment forms. The ABA has one, the AAPD. Of course, you have your Canberra form, and then you have e-forms. I've used a provisor. I haven't used my Canberra. So when should we intervene? So, you know, there's been a lot of talk, which we'll talk about in a minute, of minimally invasive dentistry. So the question is, when should we intervene surgically? And that is truly a $1 million question. I will say that intervention should be based off of how the patient presents or the clinical situation. This here is a great infographic that details interventions based off of the 3 levels of prevention: primary, secondary, and tertiary. What I like about this is that it gives you so of course it uses the ICDOS system, so you can see that there are 7 different classifications here, but it also provides guidance as to what you should be doing, the different aids that you should be using. In terms of secondary prevention, you know, they even have listed here sealants, which we're going to talk about here in a minute. Ultimately, we do need to be more conservative in dentistry. Minimally invasive dentistry is one of the many paradigm shifts in dentistry. The basic principle of minimally invasive dentistry is to preserve as much of the natural tooth structure as possible, while at the same time encouraging remineralization of early lesions to inhibit further progression. So what's the aim of these minimally invasive dentistry techniques? Repair in a manner which will minimize the structural integrity of the tooth, early detection of caries, and of course, removal of decay. So what are some of these intervention strategies? Well, there are 3 that I'm going to talk about. Number 1, eliminating or modifying these etiological factors. Of course, modifying diet and increasing host resistance. Now, this is not the end all be all, but these are just a few that I'm going to talk about this evening. So eliminating these etiological factors, we can do this by improving oral hygiene, okay, removing that biofilm. This means that you actually have to spend time to teach your patient how to effectively remove biofilm. What you do every 6 months is not going to help your patient based on what we know about biofilm and how it's formed and how long it takes. Yes, it's important for them to see you every 6 months or every 3 months, but what's going on at home when your patient is not with you? I'm saying that to say what you're doing is just not going to be enough. So your patients need to improve their oral hygiene. In addition to brushing and interdental care, chemotherapeutic options like rinses may be beneficial. Now, according to the ADA, there are two broad types of mouthwashes. We have therapeutic rinses and cosmetic rinses. So your therapeutic rinses have active ingredients to help a number of oral health problems like tooth decay or caries disease. Clinical evidence supports incorporating rinses. There are few that have been supported, and they must be used at specific concentrations in order to be effective. So typically, fluoride can help to promote remineralization of teeth. It can help prevent tooth decay, and then you have some rinses that actually help with the bacteria, which in turn will help with the biofilm. I am a huge advocate of a water flosser. There are several scientific studies that suggest water flossing improves gingival health by facilitating the removal of biofilm. So diet modification, okay, that will be really, really helpful. How can you help your patients with that? Well, first you need to perform a nutritional assessment. What is a nutritional assessment? It is a systematic process of collecting and interpreting information from various sources required for nutritional counseling. It can be used to evaluate the cause and source of nutrition-related health issues, oral and systemic health issues, actually, and it helps you to make appropriate recommendations and or referrals for your patients. This allows the dental health care practitioner to work collaboratively with their patients to assess their dietary patterns. The ultimate goal is to help patients identify healthy food choices that encourage oral and systemic health. Anytime you're conducting a nutritional assessment, it should include a comprehensive personal, dental, and social history. It should include risk assessments, clinical evaluations, and once again, a detailed diet history. The purpose of nutritional counseling is to provide practical, accurate, and evidence-based information to support and encourage positive diet behaviors, once again, that promote that oral and systemic health. So there are different counseling tips. That's not the purpose of what we're here to talk about today, but I did want to list this. When you are counseling your patients, you want to suggest certain modifications that would be conducive to your patient's lifestyle, like limiting the use of cariogenic foods during meal times, helping your patients find acceptable substitutions for cariogenic foods, and encouraging the limited use of sugar during meal preparation. So what are some of these cariogenic foods, these fermentable carbs, those foods that cause the pH to fall below 5.5? So typically everything that we love, everything that tastes so good, that starchy and sugary food, sweetened cereals, candy, cakes, yams, rice, pasta, pretzels, bread, several tropical fruits, and you have your sticky fruits. So some of your dried fruits can be really sticky, or raisins. Now, it is important to promote the use of non-cariogenic or the incorporation of cariostatic or non-cariogenic foods. And so non-nutritive sweeteners, these are good because they're not metabolized by the microorganisms in the mouth, encouraging sufficient amounts of protein and fat based on the individual patients. Protein and fat, they don't lower pH, they help to contribute to the buffering effects of saliva, and consuming these foods can help raise the pH. Sugar alcohols are really good. They have an inhibitory effect, things like xylitol, and of course, things with phosphorus and calcium. They also have a buffering effect, which helps to increase pH, and they increase in salivary flow. So when you chew hard cheeses, and I just put this here, you can get an increase in salivary flow. So what are snacks that produce little or no plaque acid? So your cheese, your yogurts, your nuts. This is, where you have wine listed here. So, wine does have some benefits, licorice, cranberries, and teas. And so there's been a lot of debate with the Stephen curve, with the foods that you eat, some foods can cause a drop in pH and other foods don't. It's important to note that when you pair certain foods, so I'm just going to use a really wild example. Let's just say if you want to drink soda, but if you're chewing cheese, maybe you can offset some of the effects of that acid. And again, that's just a really, really extreme example. Increasing host resistance. So what do I mean by that? I'm really just going to focus on the use of specific treatments or giving your patients certain products. So things like different toothpaste and creams, the use of fluorides, sealants, which are, to me, in my opinion, highly underused, and glass ionomers. So there are different creams and paste on the markets. It's important to note if you are giving your patient a cream, it should not be confused with a paste, because typically with a paste, your patient is going to brush their teeth with it, rinse their mouth out, and then they're going to rinse away anything that was in there. And typically with most creams, they need to stay in the mouth. Boco has a cream that I have personally used, my family has used. I recommend to my patients when I do provide care. It's called Remempro. This contains nanohydroxyapatite. Now, remember we said that our teeth, that enamel was comprised of hydroxyapatite. The nanohydroxyapatite in Remempro helps to fill the superficial enamel lesions and the tiny irregularities that we would never see with the naked eye. These irregularities arise from erosion, but it helps to fill these to restore the mineral balance to the tooth. Okay, so Remempro, it definitely adheres to the tooth surface or the tooth substance, and it protects the tooth against demineralization and erosion. Remempro, I call it a triple threat because it has xylitol in it. So xylitol, we know, can be very beneficial if someone has impaired salivary flow. We know that it has antibacterial effects as well. Xylitol has fluoride in it, and once again, it has that nanohydroxyapatite, which is that calcium and phosphate. So this really works to replace what is lost on the tooth surface. This product doesn't have a milk protein in it. I like to use it before periodontal therapy during my OHE sessions to ensure that the tooth is at its strongest prior to treatment. This can be applied a number of different ways. Using a soft toothbrush, you can place it in the tray, or even using it with your finger. Fluorides, we know the use of fluorides is well supported in the literature. Fluoride varnish. Again, fluoride is just not for children. If you think back to the statistics, dental caries is the #1 disease of human mankind, which means it's not just affecting children, which means we as adults can still benefit from the use of fluoride. Fluoride varnish is a concentrated form of sodium fluoride, and it's typically suspended in an alcohol and resin-based solution. It was originally approved by the FDA as a class 2 medical device, and it was cleared as a cavity liner and desensitizer. It is used off-label by the ADA for anti-caries treatment. We know when applied 2 to 4 times a year, fluoride varnish can have a considerable effect on inhibiting caries formation in both the primary and permanent dentition in children, adolescents, and anyone who is at high risk. There are a number of varnish products on the market. How do you choose? Well, you definitely want to know what your varnish is doing. Most varnish products are similar. The majority of them, again, has that 5% sodium fluoride, which is typically expressed as 22,600 parts per million. The dosage for children, of course, is lower. Most of your fluoride varnishes will have that film-forming agent colophony. Most have solvents, flavors, and sweeteners, but it's the other additives that help to aid in that remineralization, such as calcium, casein, phosphopeptide. You have arginine, zinc phosphate. The list goes on and on. Now, 2 of my favorite products would be your Pro Fluoride Varnish, which is through Boco and Pulp Dent. And the reason why I put these 2 here, I always tell people you need to know what it is you want your product to do. What is it that you want it to accomplish? So you have one, Pulp Dent, that has a sustained time release varnish, and then you have Pro Fluoride, which has an immediate fluoride release. And so if you have a patient that's really suffering from a lot of sensitivity, you definitely want that immediate fluoride release that you get from your profluoride. Another good thing with the profluoride, it does contain xylitol, but it does not contain tree nuts, peanuts, corn, shellfish. And so we know a lot of parents are really concerned with what's going in their children's mouths, but so are adults. So that's going to be really helpful here. Your pulp dent, it contains calcium phosphate and xylitol as well, and it doesn't contain any of that bis-GMA. So again, our patients are asking. For people who do not want that sticky feeling, they may have an allergic reaction to the colophony, which comes from the pine tree. You can offer a liquid fluoride varnish. And so there are definitely a couple on the market. Profluoride L, actually, I started using that off topic. I used it for whitening because it doesn't interfere with the whitening process. But again, a lot of times your adults will say, well, I don't want that sticky feeling on my teeth. I want to go back to work. Well, this is definitely a suitable alternative. I cannot stress enough the benefits of silver diamine fluoride. This to me has been a game changer in terms of minimally invasive dentistry during COVID. There were several organizations that promoted the use of silver diamine fluoride, especially to arrest caries, and I have them listed here. Silver diamine fluoride was first cleared to be used in the US in 2014. In 2016, the FDA awarded silver diamine fluoride the designation of breakthrough therapy. This is so important because it was the first for oral health therapy. There was an article in the Washington Post in 2018, James Nickman, he was the then president of the American Academy of Pediatric Dentistry, and he said that aside from fluoridated water, the topical cavity fighter, the single greatest invention in pediatric dental health in the last century is silver diamine fluoride. There are two formulations of silver diamine fluoride, one by Elevate Oral Care, the other by SDI, and it's Reba Star. What is the difference? Reba Star, they actually add potassium iodide to their formulation, so it helps to minimize or eliminate discoloration if you are using it appropriately. And this is just a picture of what it looks like. So, here on the left, you have your standard silver diamine fluoride, and on the right, you have the Reba Star that has that potassium, and you can see that there is no discoloration. Dental sealants, highly underused. There are different types of dental sealants on the market. You have your glass ionomers, you have your resin base, you have your filled and unfilled, and those that set automatically, or you need to use a current light. On this slide, I have highlighted what I feel like was important. This information was based on a systematic review, and it states that sealants are effective in preventing and arresting pit and fissure occlusal caries lesions of primary and permanent molars in children and adolescents. And sealants can minimize the progression of a non-cavitated occlusal caries lesion. So there are a lot of misconceptions about dental sealants. One is that fluoride varnish is just as effective as dental sealants for preventing occlusal caries. Well, believe it or not, varnish is really helpful, but you get a much better turnout when you place a sealant. Young patients could become exposed to concerning levels of the BPA. A lot of products now no longer have that BPA. Sealants are not reimbursable under many dental plans. Believe it or not only are they reversible, they are reimbursable for adults as well. And that sealant should not be placed over initial caries or non-cavitated lesions. That is not true, and the research supports that. There's really a lot of different sealant materials on the market. You just need to know what you want your sealant product to do. There are some sealant materials that can be used in a wet environment, others that need to be used in a completely dry environment. And this is a picture that shows product that the sealant material that needs to be used on a slightly moist tooth. And then another product that needs to be used with the tooth completely dry. What determines the effectiveness of the sealant? A number of different things. You definitely want to make sure you avoid the bubbles. Sometimes that can cause weakness in the sealant coat or incomplete groove coverage, and that can lead to sealant failure and possible decay. Glass ionomers. So what is it? It's a mixture of a paste and an acid base, and it's a reaction. It starts and it stiffens the paste. They are created by mixing an acid and a base, and it forms a salt, and that's how you get that glass ionomer. What is the advantage of using a glass ionomer? Well, it is water loving, so again, moist tooth surface, but you get that initial burst of fluoride, and then you get continued release over years. So sometimes with glass ionomers, you can heal the tooth from the inside out. You get that continuous remineralization. In addition to the fluoride release, you get that adhesion. It's flexible, so our teeth are constantly moving. So glass ionomers are good for thermal expansion, bioavailability, so you get release of fluoride, that sodium phosphate and silicate. And again, glass ionomers work well in a moist environments. So there are a number of clinical implications and patient benefits when using glass ionomers. So caries management, in closing, what do we want to do? In terms of lesion assessment and monitoring, we want early detection. We always want to make sure that we are detecting on a clean, dry tooth surface. And we want to monitor activity while using preventative strategies. We definitely want to perform that risk assessment. We want to identify these etiological factors. Remember that risk assessments help us to guide our planning, both preventative and restorative, and then we want to prevent, arrest, and remineralize through the use of different toothpaste and creams, fluorides, sealants, glass ionomers, and of course, oral healthcare instruction. What I no longer want you to say is, let's just watch it. Don't watch it. You definitely want to do something about it. What are you watching? Are you watching the tooth get worse? There's so many different things that you can do, especially for non-cavitated carious lesions. And we just talked about a lot of these things, fluoride interventions, and of course, the use of sealants. A lot of times these interventions can help slow the progression or reverse these non-cavitated carious lesions. So to recap, we talked about the etiology of dental caries. We talked about some of the latest technical advancements and their mechanism of action for preventing and arresting dental decay. We talked about the importance of using a caries risk assessment. And we talked about some current practice guidelines for evaluating, detecting, preventing, and treatment of dental caries. So I want to thank you for spending time with me. And if there are any questions, I will take this opportunity to answer them. Okay, so the first question is, for patients who drink coffee and tea through the day, what recommendations do you have? Well, I believe sipping through a straw would be an alternative. I think once you have the conversations with your patients and you let them know, what's actually happened when they're sipping on these things throughout the day, they may make the changes. Now, remember, certain teas can have a karyostatic effect. So it's not as bad as drinking coffee all day. So maybe have them, drink coffee. If they're used to drinking it over a 5-hour period, maybe try to reduce that. And then, between that time, rinsing their mouth out, maybe having them chew some gum. There's a reason why they're drinking that coffee, but there are a number of things that you can certainly recommend. As an RDH, we are not allowed to diagnose. What would you say to the patient and or to the doctor when you see a cavity that they may have missed during the checkup? Well, first, you never want to call out a doctor in front of the patient. So if it's something that you see that the doctor didn't see, you definitely want to go have a side conversation. And one thing, because we can't diagnose, I would just say that there's a suspicious lesion, or doctor, can you please check this area? There may be something there. The next question is, what is the name of the liquid fluoride varnish? It is called Pro Fluoride L, and it is through Voco. You can go on Voco's website and look for your local rep. Voco does do a lot of lunch and learn programs and can send you some samples, but you will fall in love with that product. What insurance code do you use for coverage on a sealant for an adult? The 1351, that's the same code. I don't switch it. But when I last practiced full time, I had got to the point where I did not let insurance dictate how I treated my patient. The code for a sealant is 1351, and that is the code that I used. Next question, do you use Embrace Sealant and do you have studies about long-term retention, thinking about a new product for a dental hygiene program? Yes, I have used Embrace Sealants, and that is through PulpDent, and if you go on their website, you will definitely find the studies that you need there, and they do have good retention. But it's important to note, no matter what product that you're using, if you are not implementing the appropriate technique, you are probably going to get sealant failure. How do you feel about silver diamine fluoride? Do you use it, and what have your results been? I love silver diamine fluoride. I think that it should be a part of every dentist and dental hygienist armamentarium. Silver diamine fluoride, most people use it to arrest caries and to treat caries. I use the Riva Star by SDI because you don't get that stain, or you get minimal stain, but you can also use silver diamine fluoride to help with dental hypersensitivity. And you can get that relief for up to 2 years. Now, 1 in 3 patients suffer from dental hypersensitivity. So I'm just going to throw out some random math. Chances are 2 or 3 of the patients that you see every day are suffering from some form of hypersensitivity. The good thing about a lot of the products that I discussed, you can use for a number of dental conditions. So dry mouth, dental caries, dental hypersensitivity, perio problems. And so it's important to incorporate products where you can get the most bang for your buck. We are still recommending Chlora. Why are we still recommending chlorhexidine? The stain 63%. It does, but people are recommending it because it still works. But I think people don't understand that there are alternatives out there. And so this is the beautiful thing. I say you don't do continuing education just to meet the requirements for licensure. You do continuing education to learn about different things. You go to trade shows and conventions to learn about new things. And I know that's been tough for the past 2 years, but for those of you who are comfortable and things are starting to open back up, do these CEs just to learn about what's available. You listed licorice as a non-cariogenic food. Doesn't it contain sugar and it is sticky? Yes, and there's an ingredient in the licorice that offsets that. Me personally, I can't stand licorice, and for those of you who love it, more power to you. But I don't have the specific ingredient in front of me, but there is a ingredient there, and that is why it's listed that way. Will you be sending out the slides? Thank you. I will not be sending out the slides, but this will be recorded, so you can feel free and go back and watch it. Thank you. Oh, one of my former students. Hi, Becca. All righty. Does fluoride varnish interact with chlorhexidine irrigation? So I would assume that you would irrigate first and then place the varnish. I'm going to be honest, I don't know the answer to that question right offhand. So I apologize, I don't have an answer for you. Black coffee is not cariogenic. No, it is not, but you have to be careful with certain coffees because of the acid. So again, there's so many different brands of coffee. Thank you for the presentation. What fluoride do you use on your kids? I have 2 fluorides that I use because I love them both. So that's the beautiful thing about dentistry. Just like you don't have just one pair of shoes, you have multiple pair of shoes. I have multiple products that can do the same thing. So the products that I use, fluoride that I use on my kids, are the ones that I have listed in the presentation. The Embrace line by PulpDent, and then the Pro Fluoride by Voco. The Pro Fluoride by Voco, you get so many more different flavors. And so for kids, sometimes they want a choice. So that may be an option for you. Let me keep going. So is the Remin Pro better than the MI Paste? The Remin Pro does not have the milk protein in it. The Remin Pro also has the nanohydroxyapatite. It also has the xylitol, and it also has the fluoride. So yes, in my opinion, it is definitely a much better option. Thank you, thank you, thank you. Hi, Dr. Chen. Thank you, thank you, thank you, everyone. So once again, thank you for spending time with me. I do want to take an opportunity for those of you who may be in Texas, sending prayers to you. You know, what's going on in the news is heartbreaking. And so just everyone say a prayer for those babies that may have lost their lives today. Thank you so much.